And we'll go straight into our next presentation on reimagining a world without Alzheimer's dementia, novel approaches to diagnosis and treatment. Dr. Ryan Punambolam is a Canadian-trained neurologist, neuropsychologist, and new neurologist at Doctors Hospital, Cayman. Dr. Ryan, the podium is yours.
Thank you, Mr. Chairman, and thank you all of you for being here bright and early on a Saturday morning. It's interesting how when you're British, you automatically sound smarter. I wish I had a British accent. So I'll tell you guys a secret. I never wanted to be a neurologist. In Canada, we have a 4-year of undergraduate medical education. In your 3rd year, you spend it rotating through all the specialties. And I loved everything. I loved pediatrics, obstetrics, internal medicine, everything except neurology. And so at the end of your 3rd year, you have to start applying for your residencies. And so I sat down with my mentor, and he was an epilepsy specialist. And I said, sir, one thing I know for sure, I don't know how to decide, but I'm not going to be a neurologist. And he said, well, why? And I said, well, neurologists are pretty nerdy. And all the doctors know that. Neurologists are super, super nerdy people. And it's a hopeless specialty. It's dementia. It's stroke. High-grade brain tumors. I wanted to be a winner, right? I wanted to be an orthopedic surgeon. I was going to fix knees every day of my life. People are going to love me. They're going to bring me wine. And it's going to be tremendous. But I'll tell you, my mentor put his coffee down, and he said, son, I'm going to teach you some life lessons right now. And he said, we are meant to do not the easy things, but the hard things. We are not meant to do the possible, but the impossible. The primary role of a physician is to bring hope to the hopeless. And so I remember that line every day, especially when I have those hard days, because I don't win every day as a neurologist. And so that's why I'm cutting to the punchline. This is ultimately, the theme of this talk is about hope. And I think sometimes us doctors are forgetting that. And maybe that's one of the reasons why you guys don't come to us anymore. How many times do you leave your doctor's office feeling hopeful? So I'm going to buck that trend. This was an impossible dream 10 years ago, but now it is within our reach. Can we detect and prevent dementia before it starts? So in the end, this is a talk about hope. And it's fitting because this is also a talk about, I don't know if it's going to play, but, oh, it's too bad. Anyways, this is also a talk that fits well into the ecosystem theme. To me, an ecosystem means connection to ourselves, to each other, to our communities, to our world. If this video worked, oh, it's working now. Those are 2 neurons under a microscope. And what are they doing? They're reaching to each other. They're connecting. We are hardwired to connect. And do you know the power you have in your brain? The power of your brain is in those connections. We have more connections in our brain than there are stars in the Milky Way galaxy. Your brain is your most important resource. Take care of it, and it will take care of you. Now, more hope. Typically, when I do talks, I leave the drugs, the therapeutics at the end. But again, I'm pulling this to the forefront. Across the history of medicine, 99.9% of all Alzheimer's clinical trials were abject failures, costing billions of dollars, until last year, a miracle happened. In January 2023, there was a trial of, lecanemab. And lecanemab is a twice-monthly immunotherapy. And the way it works, and I'll talk about this in a couple of minutes, it latches on to an abnormal protein in amyloid in Alzheimer's brains called amyloid. And it helps the patients with early Alzheimer's It allows their immune system to clear that protein away. And what we saw was something amazing. You can see on the top slide, the treatment group had very effective clearance of this abnormal protein. But what was most remarkable is this slide here. For the first time ever in the treatment arm, there was slowing, not a cure, not reversal, but there was a slowing of the cognitive decline. This was the first time in the history of medicine. And it gets better. In August of 2023, there was a second trial. There was a cousin called donanemab. Again, it's an infusion, and it's a once-monthly infusion. And again, it helps patients with early Alzheimer's clear the abnormal protein from the brain. And you see, it's very, very effective at doing that. And again, what did we see? There was a slowing, not a reversal, not a cure, but there was a slowing of the cognitive decline. That has never been seen before. But although there's cause for hope, it needs to be tempered. This is not an infusion that you go to a strip mall in West Bay to get it done. It requires careful patient selection and expert monitoring. Because remember, one of the ways this therapy works is you get a profound immune response in the brain. And when that happens in the brain, two things can happen. You can get swelling and you can get bleeding in the brain. And this happens about 20 to 30% of patients in the treatment group, typically in the first few months of treatment. Fortunately, a lot of these brain changes were found as part of routine MRI monitoring. But in 6% of patients, the researchers had to stop the treatment because the swelling in the brain bleed was so sufficiently severe. So again, there's reasons for hope, but it must be tempered by careful patient selection and expert monitoring. Let me take a step back. What do I mean by dementia? Dementia means two things. It means loss of memory along with other brain function, language, orientation, among other things. And that has to be combined with a loss in your ability to do your day-to-day functioning. Now, dementia is an umbrella term. It's a syndrome of which Alzheimer's is the most common type. And in real life, Alzheimer's is difficult to diagnose for a couple of reasons. For one, it sneaks up on us. We don't recognize it in ourselves, and we don't recognize it in our family members until it becomes very, very obvious. And second, we make a mistake. As you get older, you're allowed to slow down. You're not allowed to lose. You're not allowed to lose memory, orientation, language. And oftentimes, even when you take your grandpa to the doctor, they discount it as normal aging. That is false. You're allowed to slow down as you get older. You're not allowed to lose. If you start losing brain function, it may be an early sign of dementia. What about the numbers? The most important unmodifiable risk factor for dementia is age. 50% of all 95-year-olds on Earth have dementia. And things are going to get worse. By the year 2050, there will be a tripling of the amount of patients on Earth with dementia, 150 million people. That will put strain on you, on your caregivers, on your family, on every healthcare system on Earth. Cayman will not be spared this hurricane of dementia. And as of right now, there is a single outcome. Once you're diagnosed, on average 5 to 10 years from diagnosis, the only outcome is death. In fact, it is the leading cause of death in the UK. But we also know that some of the risks vary on a personal level. You might hear some doctors say that Alzheimer's is not genetic. That is not true, entirely true. There is an important genetic risk factor called ApoE. We all have ApoE. We actually have 2 copies of the gene. And there's 3 different variations, ApoE 2, 3, and 4. And so if you do the math, there are 6 different isoforms, 2, 2, 2, 3, 2, 4, 3, 3, 3, 4, 4, 4. If you have the ApoE 4, isoform, your lifetime risk of dementia is 50%. It's not a guarantee, because if you flip it the other way, 50% of patients do not develop dementia. But this is an important genetic risk. And where you live matters. In terms of highest prevalence of dementia on Earth, North Africa, silver medal goes to Latin America, bronze medal goes to here, the Caribbean. We live in the 3rd most prevalent area on Earth for dementia. And if you're a woman, guess what? Your risk of dementia is almost twice as high as men. And it is the leading cause of dementia. It's the leading cause of death in women since 2011. I hear a lot of murmurs. I take this seriously because if this is the first time you heard a bit about this, we have failed you as a health system. And it gets worse. If you're of Black ethnicity, you have a higher risk of dementia, and it happens on average 3 to 5 years younger than white patients. And not only does it happen younger, you die more quickly than white patients. This, friends, is not biological in its entirety. This represents health inequity, and we need to face it. This is hard data to look at. We need to face it and design a system to address these health disparities. The Attorney General of the US says that we are living through an epidemic of loneliness. We know that social isolation, especially at an advanced age, carries a risk of dementia 6 times higher than patients who are socially well-connected. Again, that ecosystem theme, that connectivity theme. Social connectivity protects you from dementia somewhat. So what does the brain look like grossly in a patient with Alzheimer's? Well, it looks like this. For reference, this is a normal, healthy brain. And an Alzheimer's brain looks kind of shrunken, doesn't it? It looks atrophied. It looks degenerated. The spaces around the brain and within it enlarge because that brain has already lost billions and billions of neurons. But what's driving this change? We know at the cellular level, and this is called the amyloid hypothesis or the amyloid cascade hypothesis. In our brains, we all have amyloid. Amyloid's a normal and important protein. When the brain is done with amyloid, it cuts up the protein or it cleaves it. For some reason, in patients with Alzheimer's, the processing of that amyloid protein is different. The way it's chopped up is different. So what happens is those pieces of amyloid start sticking together like Lego blocks. And they get bigger and bigger and bigger. They form protofibrils and fibrils. Our immune system can no longer clear it. And what happens? They stack on each other and they form plaques. Those plaques then interfere with normal nerve cell function, and through a variety of mechanisms, including inflammation, we start seeing nerve cell death. So we learned about amyloid plaques, and a little bit later on in the cascade, we see a second protein called tau. And now tau doesn't cause plaques. When tau accumulates in the Alzheimer's brain, we get tangles. So I'm going to quiz you guys on that pathology. We're going to come back to it over and over again in this talk. Amyloid plaques and tau tangles. Plaques and tangles are the 2 central pathologic processes in Alzheimer's. And although those cartoons are nice, those microscope pictures are nice, life is not so nice. Life is mixed up. When I said that Alzheimer's is the most common cause of dementia, in real life, that is not entirely true. We know that in real life, we often see mixed pathologies. And what I mean by that is we see an important interaction between Alzheimer's pathologies, remember the plaques and tangles that you guys learned about, and blood vessel problems. Remember, plaques and tangles drives inflammation in the brain. Inflammation in the brain starts to pick off small microscopic arteries in the brain. And what happens when arteries are clogged in the brain? We get strokes, microscopic strokes. That drives more nerve cell death, more inflammation, more plaques and tangles. So it becomes a vicious cycle. This is a bad marriage of amyloid pathology with blood vessel problems. And this is what it looks like in real life. This is a patient that I saw a couple of months ago, soon when I started here. For reference, this is a healthy 25-year-old brain. Look at the 75-year-old brain. He came to me with memory loss. And you see on the outside of the brain, it looks shrunken, doesn't it? Right? Their space is enlarging. But look here, see how that white patchy? It looks not very nice, and it's not nice. That is microscopic strokes that are clogging off the area of the brain called white matter. And white matter is important for brain connectivity. So this patient has mixed Alzheimer's vascular pathology. And we know it's a bad marriage. He's going to have a very aggressive course and a more rapid decline. We're going to come back to this blood vessel thing a little bit later when we talk about how to prevent dementia. So remember it. We learned about what an MRI looks like in an Alzheimer's brain. In reality, if you're seeing brain shrinkage on an MRI, it's quite late in the game. That patient has lost billions of neurons already. There are techniques, functional imaging techniques, that we can use to detect abnormal protein in the brain a little bit sooner. And it helps us detect Alzheimer's perhaps sooner in the process. And it's called a PET scan. And what we do is we inject patients with a radio label, and it attaches to a specific protein in the brain, and it lights it up. In this panel here, this is a radio tracer for, guess what? Amyloid, right? Remember plaques and tangles. This is a normal amyloid PET. There is some red there, because remember, amyloid is a normal part of everybody's brain. But if you look down here, see there's a deeper red, and the distribution's a little bit deeper. You're seeing deeper amyloid in the deep parts of the brain and in the back part of the brain. That's typical of Alzheimer's. This is lighting up amyloid plaques. This next panel here is, remember we talked about the tangles. So this is a radio tracer that's attaching to tau. And you can see this is a normal brain, very little lighting up. But look at down here. Lots of yellow, green, some red. That is abnormal tau deposition in a patient with Alzheimer's pathology. So this functional imaging, the PET scans, are a useful tool for early detection. So now that we know a little bit about the numbers, the definitions, and we really know a lot about the pathology now, what are the risk factors? So remember our friend here, right, who is losing memory. He had the blood vessel problem compared with the amyloid pathology. So it's no surprise that a lot of our preventative strategies and a lot of your risk factors relate to blood vessel problems. What are blood vessel risk factors for small vessel strokes? High blood pressure, diabetes, cholesterol, smoking. If you have those, your blood vessels are in trouble. When your blood vessels are in trouble, your brain is in trouble. Because remember, microstrokes drive inflammation, and it drives amyloid plaques and tangles. Let me take a step back. You might not know that depending on which stage of life you're in, there are different risk factors that apply to you. In early life, one of the risk factors for dementia is lack of education. And one thing your government has done well for you on island is you guys have excellent access to high quality education and high literacy rates. That is protective against dementia over the long course. If you didn't have access to that high quality education, your risk of dementia years later is much higher. And in late life, things like loneliness, exposure to air pollution, and visual impairment are risk factors of dementia as you get older. But we're going to focus on you guys, late 30s, 40s, 50s, early 60s. You may not know it, but what you did yesterday, what you're going to do today, and what you're going to do tomorrow is going to lay the groundwork for how healthy your brain will be when you're 70, 80, and 90. And sure, there are important things like hearing loss, depression, head injuries that, if they occur in midlife, carry with them a higher risk of dementia. But I'm going to focus on these things, what we call the vascular risk factors or the cardiometabolic diseases. Those are things like high cholesterol, not exercising, diabetes, smoking, hypertension, obesity. We're going to talk about how those vascular risk factors increase your risk of dementia. And this is a good example of how powerful your blood vessels are in terms of dictating your brain health. Remember, I talked to you guys about the ApoE44, that genetic risk factor. If you have that, you have a 50% lifetime risk of dementia. But if you have ApoE44 and you have high blood pressure, if you're overweight, or if you've had a stroke, forget about it. Your risk of dementia goes through the roof. So if you have that genetic risk factor, you cannot afford to have bad blood vessels. So how do we prevent it? So some bad news. Every one of us in the room, like it or not, day by day, year by year, decade by decade, we're accumulating plaques and tangles in our brain. It's scary, but if you do an autopsy of 1,000 95-year-olds, all of them at autopsy will have plaques and tangles in their brain. But remember, what's the theme? The theme is hope. So, this is a little bit of a complicated study. I'll walk you guys through it. But it's important. This is an autopsy study where they looked at patients after they died. They examined their brain tissue, and there was two patient groups. Those with dementia is the orange line, and those without dementia is the blue line. And they focused on one area of the brain called the hippocampus. And the hippocampus is important for memory, recent and immediate term memory. And what you see here in the first slide is, and it makes sense, remember in Alzheimer's brain, we start to see brain shrinkage or atrophy. The hippocampal structure in those with dementia was much smaller. The degree of atrophy was much greater than those without dementia, the blue line people. That makes a lot of sense. But focus on the middle and the last panels. There's something very interesting here. At around the age of 90 to 95, look at what happens to the curves. The amount of amyloid plaques, so when pathologists didn't just look at this size of the brain, but they counted the plaques and tangles that we learned about. Around 90 to 95, the two curves converge. So what that means is that the patients with dementia and without dementia, between 90 and 95 years old, had the exact same amount of plaques and tangles. That doesn't make a lot of sense, because doctor, you said Alzheimer's is caused by plaques and tangles. That's not the full story. There's something magic about these blue line people that despite accumulating plaques and tangles every year, every decade, they are resistant to the impact of that pathology. And the magic sauce for those blue line patients is something called cognitive reserve. I'm going to tell you the story of two grandmas, Grandma A and Grandma B. They both live on Cayman. They're both 80 years old. Grandma A looks amazing. She looks younger than her age. She's not overweight. She exercises every day. She eats right. She volunteers for her church. She's constantly learning new languages. She takes her blood pressure medication. Her blood pressure's perfect. Her doctor says that her sugar's a little bit high, but she's watching it with diet. Then there's Grandma B. Grandma B has a bad knee, so she doesn't walk much. Because she doesn't walk much, she sits at home, watches TV. She doesn't like going out. She's isolated. She's probably depressed. She doesn't eat right. She doesn't take her pressure pills. She doesn't take her sugar pills because it makes her feel sick. Her hypertension and diabetes are through the roof. Both of these ladies are the same age, and remember I said, year by year, they're going to accumulate plaques and tangles as the years go on until they hit a point of inflection. But see what happens to Grandma B. Grandma B hasn't invested into her brain health. And look what happens. When she reaches that threshold, she falls downhill into the abyss of dementia very, very quickly. But look at Grandma A. Grandma A has spent her entire life investing into her cognitive reserve, her brain health. And so, despite developing plaques and tangles as we all get older, like she did, she might slip, but she doesn't fall. She is so high up above the threshold of dementia, she never develops clinical dementia despite developing the pathology. She is resistant to it. And so now you guys know the secret of how we're going to prevent dementia. We do it in two ways, negative and positive. And what I mean by that is negative things. Don't have high blood pressure. Don't have diabetes. Don't be overweight. Don't smoke. What I mean by that is don't be poorly controlled. Those are your risk factors for damaging your blood vessels. You don't want those because you want healthy blood vessels. But we're going to do things in a positive sense. Your brain is a muscle. You want to build it up. How do we build up your brain muscle? Education, social engagement, mental activities, social activities, exercise, and diet. That's going to build your brain muscle. And look what we're doing. As we build your brain muscle and we make your blood vessels healthier, it increases that cognitive reserve. And that's the secret. And how do we do it? It's easy. 5 fingers. Diet, exercise, mental activity, social activity, and optimizing your vascular health. And I'm not making this up. This is not voodoo. This was studied in a randomized controlled trial. It's 10 years old now. It's called the finger trial. And what they did is they separated people with early to middle Alzheimer's. Half of them had the 5-finger treatment, the other half just normal care. And at 2 years, something amazing happened. The researchers found that the people that had that 5-finger method that we just talked about had better executive function. They were better decision makers. They had better attention and better insight. And they also were sharper. They had faster processing speed than those patients who were not treated with the finger method. So again, the finger method does tremendous things for our brains. One thing I have to remind myself of sometimes is that I'm not a preacher, I'm a coach. And I'll tell you guys, the good thing about me is I'm imperfect. And I know you guys are now junior neurologists. You guys are brain health advocates. You guys are gonna run out of this room and give your husband, your wives, your son-in-law a hard time. I don't expect you guys to be perfect. I know what it's like. You have a young family, you're not sleeping, you don't have a minute to yourself. You feel like Alice in Wonderland, right? How many of us feel like you're running as fast as you can just to stay in one place? You don't have to be perfect, and I'm gonna prove this to you guys. You just need to do a little. Try to hit each of those 5 categories, and a little bit does a lot in terms of your brain health. This is a study called the Whitehall study, and they have a scoring system that grades how healthy your lifestyle and vascular risk factors are. There's 7 categories. A perfect score for each category is 2. A perfect total score is 14. 2 points for never smoking. 2 points for a good diet, defined as more than 2 servings of fruits and vegetables per day and high fiber. 2 points for exercise more than 150 minutes per week. 2 points for well-controlled diabetes. 2 points for well-controlled cholesterol, and 2 points for a blood pressure less than 120/80. And in this study, there were some crazy patients. They had a perfect score. That's not me, that's not you. A lot of the patients, most of the patients, were kind of in the middle. What I suspect, though, is perhaps one of the reasons why we have such a high prevalence of dementia in the Caribbean is a lot of us are maybe down here. We're 2, 3, 4, and 5. Because in reality, a lot of us are scoring 0s and 1s in those categories. And you can see you don't want to be low on this scale. Because if you have a low lifestyle score, your risk of dementia is through the roof. But one thing I want to highlight to you guys, yeah, if you're one of those perfect people, they're rare, your dementia risk is low. But I want to highlight that the people like us that were less than perfect, the 8, 9s, and 10s, they were scoring 1, maybe 2 points in those categories. Look at their dementia risk. It is also low. So you don't have to be perfect. You can be less than perfect, but try to hit one of those 5 fingers. It will have a tremendous impact on reducing your dementia risk. And sometimes people ask me, well, doctor, what do I do? Where do I start? And you start where I started, and it's with walking. The ideal amount of steps in terms of dementia risk reduction is 9,800 steps per day. That's ideal. But what I tell patients is, remember, I know what it's like to be Alice in Wonderland, right? Start somewhere. As little as 3,000 to 4,000 steps per day. I do that on my lunch break. It's 15 minutes. That reduces your dementia by 25%. It costs nothing. You can do it on your lunch break, but that's where you start. You start by walking. One thing, however, that we learned is that we're starting to personalize dementia risks. Remember, there's lots of variability. Your risk is going to be different from your neighbors, then your cousins, then your husband, then your wife. What precisely is your risk? And that's an important question to ask yourself. It's scary, but it's better that you know now. And that's really the paradigm shift. We now have a way to assess personalized risk. We're looking at now precision, evidence-based, and a comprehensive way of risk stratifying dementia. And an important concept is, remember, when you start losing memory, when you start seeing brain shrinkage on your MRI, that's getting late in the game. A lot of the plaques and tangles are happening years, if not decades, before clinical symptoms. And what's the problem with how we diagnose dementia now, right? You have your grandpa, and remember, Alzheimer's sneaks up on us. So you're not going to recognize in the beginning. But you notice grandpa's forgetting his glasses. He might be forgetting the date. It's now pretty obvious. And you take him to your family doctor, and what does he say? Don't worry about it. It's just normal aging. Come back and see me 6 months later if it gets worse. So you come back. Grandpa's now leaving the stove on. He's getting lost when he's driving. It's really bad. Your family doctor then does a pen and paper test, which is not very great. It's not a very good screening measure. He maybe does an MRI, and yeah, you see brain shrinkage, but it's too late. He maybe does some blood work, and then he might start your grandpa on an older medication called cholinesterase inhibitors. It does nothing for the pathology of Alzheimer's, not very effective, and about a third of patients drop it because of side effects. And what happens? No surprise. Grandpa's gone in 5 years from diagnosis because we were late in the game and we weren't very effective. We didn't set up a personalized approach to treating his disease. And this is the problem. We're catching grandpa when he's already underwater. We need to catch grandpa here, if not sooner, in the pathologic process. And what has now revolutionized early detection of Alzheimer's are blood tests, blood biomarkers. Remember I talked about that PET scan that you infuse patients and the proteins light up? There was a pretty scans. Those are amazing. But what's the problem with PET scans? They're bloody expensive. And access, even where I'm from Toronto, US, UK, Europe, access is a problem. So we knew from a population perspective, PET scan was not the answer. These biomarkers have revolutionized our capacity to actually detect early Alzheimer's pathology sooner. And guess what they test for? Among other things, plaques and tangles, amyloid and tau, specifically A-beta 42/40 ratio in your bloodstream, and p-tau 217. We can do this now. An important thing is it's not yet, we don't know how valuable it is if I were to randomly do blood tests on everybody here. So I'm not going to set up a booth in the lobby of the Ritz after this talk. But the way I use it is if you come to me with memory issues, I test this. And if they're elevated, it's a tool that makes me say, I'm going to have to watch this lady a little more carefully. I'm going to push the 5 fingers. I'm going to follow you up a little bit more closely. And again, we're trying to catch people in this phase where you're starting to lose memory and cognitive function, but your day-to-day functioning is still spared. That is what we call mild cognitive impairment. And remember I showed you guys those 2 infusion trials at the beginning of this talk? One of the reasons why those trials were successful is they were treating people up here, not down here when it was already too late. So again, early detection, prevention, and treatment is the key for us to make an impact in terms of dementia care. And don't blame your doctor, don't blame yourselves if we're late at catching it. We haven't yet set up a system worldwide. We are poor, and it's our fault as neurologists. We're not very vocal people. So we have to set up a system to help you. And the reason why we're failing is that this is hard work. I have a lot of gray hair trying to do this. Look at all the things we have to do. Blood vessel problems, exercise, cognitive reserves, biomarkers, maybe infusion therapy. This is not easy. I can't do it alone. The way we do it is, guess what? An ecosystem. That's you, it's your family, it's your community, it's your church, social worker, pharmacy, nurses, and your healthcare team, dietitians, exercise physiologists. Everybody bringing their expertise, learning what your risk is, learning what your life is like, and personalizing the approach. This is how we're going to win. And I'm proud to say this is what we have now on island. This is cutting-edge, evidence-based, cost-effective approach to early detection, treatment, and therapy in some cases for dementia. Your brain deserves it, and certainly we need to get started. I once got in an argument with one of the radio hosts on island. She had said that the most important economic driver on island is financial services. And I'll tell you guys, that's BS. What is the most important economic driver on island? It's you, right? It's the heart, soul, and minds of the Caymanian people. And I'm biased. I think your mind's your most important asset. A healthy brain is richer. There's evidence for that. It's connected, it's innovative, it's creative, it's compassionate. But you need to invest in it. What you did yesterday, today, and tomorrow is going to lay the groundwork of what your brain looks like when you're 80. Don't come to me when you're 80 and forgetful. It's already too late. You 30-year-olds who laugh, now is the time. Invest in your brain, because if you don't, you're going to have a sick brain, and we don't want a sick brain. A sick brain is poor, it's rigid, it's disconnected, it's anxious, it's depressed. Invest in your brain. It doesn't take a lot, but if you take care of your brain, it'll take care of you across a lifetime. And that's it. Thank you, guys. Yeah. Maybe I should have been a preacher, eh? Yeah. I think preachers get paid more, I hear.
Thanks, Doc, for this presentation. Based on the feedback, do we have any questions? We do have at least one question at the back. We'll get you a microphone. Yeah, the microphone is good.
Good afternoon, everyone.
Good morning.
I think the presentation was very brilliant and educative presentation. I'm Paul Williams. My question to you, based on your presentation on also your experience, clinical experience, if you compare the Caribbean versus countries in which you have a socialized health system and in which the population is more able to get health care, is the incidence and prevalence of dementia less or greater in those countries?
That's a good question. Essentially, the question was, if we have essentially a healthcare safety net where we have access, easier access to healthcare, will that make an impact for dementia? In terms of background, I'm Canadian, so I'm still getting, I'm not a big fan of this insurance stuff and this billing stuff. I'm biased. I'm going to remind you guys, who's the most important person in terms of dementia care? It's not me. I'm a stroke neurologist by training. I did a master's degree in dementia because when I graduated, there was not, in 2011, when I wrote my fellowship exams, we knew nothing about dementia. So I had to retrain. One of my professors said the most important stroke neurologists are family physicians. And the same applies here. You guys don't want me. I'm expensive, right? We know specialist care is expensive. We over-investigate. And when you're seeing us, it's too late, right? I think when I win the lottery and I retire, I'm going to take my briefcase and I'm going to travel around. I'm going to treat diabetes, hypertension, cholesterol, smoking cessation, right? Those are cost effective. There was actually a Lancet article looking at the cost effectiveness of those interventions, and they are cost effective. So yeah, absolutely. I think ready access to primary care is super important, because remember, it's blood vessel problems fundamentally. It's early recognition. And so yeah, if I have one dream for the island is, and one point of frustration, and I don't mean to offend anybody, but I want to see everybody. It saddens me that some patients can't come to me for various reasons, and that grieves me tremendously. And so one of the things is, if we have good access to primary care, absolutely, that will make a difference in cancer. That will make a difference in everything. But absolutely, you're absolutely right. I think we will see better numbers.
I think we have time for one more question over here. Okay, so we'll take this question, then we'll have one final question.
Very excellent presentation. I'm here. Here.
Oh, there you go. Sorry.
Very excellent presentation. I think I need to come and find you. I'm just wondering, though, is the special blood tests that you mentioned, are they covered by the insurance company?
I can't speak for all of them because I'm new to this insurance piece. We are already sending them off in selected patients, and they are covered by third-party insurers, absolutely.
We had a gentleman up at the front to my right with a question. We'll get you the microphone.
He's an orthopedic surgeon, so he's going to be a hard time.
Thanks, Ryan. Just a quick question. Do we have any, are there any surveillance programs that, like prevention programs that are available, or early interventional, early detection programs that are available to get communities checked up, like you know how we do for stroke? We have, you can have prevention programs or early detection programs. Do we have something like that for dementia?
Yeah, so that's a great question. The question is, do we have an early prevention? So that is that patient flow diagram, that clinic is designed for those three purposes: early detection, prevention, and treatment. One of the problems right now is, how do we diagnose dementia early? And a lot of the times the doctors will know that we use the MMSC or the MOCA. It's problematic. There's cultural bias with those, but it's the best we have. But we now have, and actually we're leveraging AI and smartphones. There are now early programs that we can deploy. I can do this entire room in 5 minutes for cents on the dollar. That's going to be where we're going to detect. I think the problem is that we can't capture these people soon enough. So you're right. Where we're going to make the biggest impact is catching them early with early detection and prevention, absolutely.
Did we have one other question? And then we will need to wrap to get us back on time.
Sure, thank you for allowing me. This was an amazing presentation. I have a question. I'm a psychologist and I work on the other end of brain health and brain development in young children. And I'm wondering if there's any research or correlation when there's executive dysfunction or memory impairment from early childhood. Does that increase risk? Is there any connection there at all?
So the question is there in young kids who have brain diseases of various causes, and they may have problems with executive function, decision making, does that carry a risk of dementia? It depends. And as you know, it depends on the cause, right? If it's a genetic cause, if say they had perinatal brain injury with a stroke and cerebral palsy, absolutely they're at heightened risk because they have structural brain abnormalities. I love kids though, because they can they're so resilient, and you probably see it every day. I've seen patients who have had strokes as a baby, and I see them 13 years later and they're playing volleyball. It's crazy how resilient. If that happened to you or I, we would never go home again. So I'm hedging my bets. I respect the potential. I never count a kid out. But certainly, if they have early brain issues, it carries a higher risk. We also know that early childhood trauma, right, deprivation is an important risk. That's why we're very fortunate here. Because of early childhood education, there is social supports there, and that's protecting the young brains. But absolutely, I think in general terms, it would put them at higher risk.
Thank you very much, Dr. Ryan.
Thank you, guys.